So we're going to get started again. So if we can ask Dr. Rob and we'll say Dr. Staci, and especially at camp, we become a little less formal. Is that okay with you, Dr. Staci?
Of course.
Thank you. All right, thank you for coming back promptly, and we'll get started. And so any question that you didn't ask, we'll get going. Thank you.
So can you help us understand, because a lot of the information provided this morning was regarding classic Fabry disease, regarding the studies, if there are any studies being done on non-classic Fabry disease, and when symptoms usually start presenting themselves that you find? Because my family, we have the non-classic, but we have many of the same symptoms as classic, but then there's information online that's not out there that says that you shouldn't have this symptom or it shouldn't present themselves.
So part of that is that's the things that we have been taught. So I started seeing patients with Fabry disease in 1997, and at that time, I met a few of them, and they came in, and it was supposed to be an all-male disease. And everybody that I saw for the next 2 or 3 years, which wasn't a big number because there weren't treatments, so people didn't come in. But I saw a number of patients, and all of the men with Fabry disease that came in to see me were accompanied by female family members who told me they had symptoms. So when I went to a meeting for Fabry disease, there was a panel of experts. And I said, well, what about the women? My experience is that all of the men that I know have at least one symptomatic female relative. And I was told that I needed to go back to medical school because I clearly didn't understand X-linked inheritance. I was a little bit offended by that. So I went home, and instead of just pouting about it, I recruited a graduate student, and we did a survey of 200 women who were obligate to have a variant, the familial variant for Fabry disease in their families, and we gave them about 30 pages of questionnaires to fill out on their health, and found that about 75% of the women ascertained because of where they were in the pedigree had symptoms. And Bill Wilcox did that, only he brought the women in and did echoes and MRIs and lots of medical testing on that, and he found the same thing. So it turned out the assumptions based on what we know to be the biology were wrong. And what we are functioning on right now with the non-classical disease is the same assumptions. We're assuming that the biology is going to be this way because that's the way it is for other diseases. I think that's a mistake. We need to do actual studies. And we know that there are a few mutations or variants that have been looked at in detail. The N215S has been looked at in a lot of detail. The Taiwan mutation, that's a splice mutation, has been looked at in a lot of detail, and they are very different between the two of them. N215S looks and behaves a lot like classical Fabry disease, except that it's a little bit later onset. And the Taiwan mutation looks like mostly heart disease, and you have to look really hard for any evidence of additional signs or symptoms. You can find some evidence of kidney disease. And I think we're going to find that kind of variability all over the place. So it's a good question. There's not a lot of data.
And I would just add that I think as healthcare providers, we really like to put diseases or types of conditions into boxes and say this is classic or late onset disease, or this is how N215S behaves, or how the Taiwanese variant behaves. And people don't exist in those boxes, and we know that even within your family and even within people of the same sex within your family. So if you have multiple females in your family, Not everyone has symptoms, the same symptom onset, so we know that really this exists across a spectrum, and that makes it really hard to predict. We also know that there are a number of natural history studies that are ongoing. So if you participate in registries, those are really helpful and beneficial for us gathering information about the more rare variants and about the disease overall from large groups of people, which help us not tell us exactly what will happen to you or your family, but to people on average at least.
Yeah, and we also have a plan for at least some of those registries to do sub-analyses that are specific to non-classical so that the symptoms that are identified are not overwhelmingly blocking out or representing the classical that's already known. That will be helpful.
Thank you.
Okay, I'm just going to show my age here for a second. I'm very interested in women with Fabry and peri and menopause. Anybody doing anything with that? And it's okay if not, because I know kids are important too. But just wondering. Thank you.
At the risk of showing my age, this is a really popular topic these days, I think, in general. And I think there is, on the plus side, more awareness of perimenopause and menopausal symptoms in general. And on the negative side, a lot of dismissing of these symptoms and the impact of these symptoms, both in general and on people who have other chronic illnesses. I'm not aware of any specific research on the implications of perimenopausal or menopausal period on people with Fabry disease or of Fabry disease on people during that period of time. But I think certainly this is data that should be collectible. I don't know if you know of any other studies.
There's no published studies. There are anecdotal reports of symptoms. What we don't know is, are those symptoms that are significantly, if we look at a population of people, are they significantly different than the symptoms in the general population? How does that compare with people with other chronic health conditions? Until very recently, one, we didn't have enough patients identified. Two, females were presumed to be not affected. And three, we didn't have analytics that were sophisticated enough to be able to do this. So about 3 years ago, there were the first calls for what do we do with people who are above age 50 with Fabry disease. The fact that we have to ask that question is a really good thing, but it hasn't been done yet.
So we should definitely start before 50.
Yes, we should definitely start before 50.
I won't put myself in that group. I'm not, yeah. But the other thing I'll say is I think whenever we deal with a chronic illness, we talk about Fabry disease and then we talk about common illness, people have multiple experiences. One where everything is chalked up to your Fabry disease, one where everything's told it's not your Fabry disease and it's something else. And when you talk about conditions that could have overlapping symptoms, it becomes really tricky. So if you come in and you sit in my office and you tell me that you have Fabry disease and you're female and you're 48 and you are having all these heat intolerance symptoms, I am not smart enough or psychic enough to tell you which it's causing your symptoms, but I think that we owe our patients the benefit of considering all of the possible options and then also thinking about treating all of the possible causes either in a stepwise way so we can figure out what is causing them, because the ultimate goal is, what's most important is not, is it Fabry, is it perimenopause, is it both? But is how do we get you to feel better? And so I think you need to have physicians and healthcare providers who are open-minded enough to think about all of those possibilities and to help find solutions regardless of what the cause is.
Yeah. And the reason I picked age 50 is that in the last big meeting that I went to where this kind of a topic was proposed, a group of legitimate experts in Fabry disease made a statement that they thought that women over age 50 who had been healthy up until that time could essentially be ignored. And I strongly objected to that. And voiced my concern, and there was a lot of discussion, a lot of controversy. This is a really important topic, and it needs to be addressed both for men and women. The first time we tried to look at men in an older age group, there weren't any. We weren't identifying any non-classical patients at that time, and none of the classical patients made it that long. Now we have both the ability to find the non-classical patients and the men living into their 70s. And I have female patients who are in their mid-80s, and they have definite healthcare needs that are related to Fabry disease. We just need to analyze the data, well, collect and analyze the data.
And Em, I'll share with you that we are planning a webinar on female topics. So I'll pay a little bit of paid advertising here. If you've seen our YouTube index, there are 60 videos that we've produced on various topics, and we'll add that one soon and help with that issue if we can. Those topics, not that issue.
Hi there. Is Dr. Dawn going to be part of the panel as well?
I think she's in the kid sessions
Oh,
right
okay.
now.
She's with the teenagers.
That's great. Because my question relates a little bit to what she spoke about. With more newborn testing occurring in some states, is Fabry disease more common than what was traditionally known?
It's a great question.
And then also kind of the second part of that question
Rob
is,
laughs.
is there also, do we have the ability to scale up treatment for what could be more patients?
They're great questions. I think we know from newborn screening across many diseases that as we start to do newborn screening, we find that the incidence that is much higher than we anticipated. We also find that the characteristics of the population are different than we anticipated. So, as Rob alluded to, historically, we only identified people with classic Fabry disease, and we didn't know non-classic existed, or we are missing many people. We know that we're underdiagnosing rare disease in general. We especially are bad at diagnosing later onset conditions because they may look more mild. They may present in adults who we chalk up their symptoms to other things. We are less likely to do broad genetic testing on adults than we are on children. So we certainly find that that there are more people with Fabry disease than we expect. Some of the newborn screening studies in some countries have found it to be even lower than 1 in 1,000, so 1 in the order of 700-800, depending on. And we also find that there's far more later onset or non-classic disease than there is classic disease when we do newborn screening. So to be determined where that number falls out if we ever have newborn screening universally. But certainly we anticipate there's far more Fabry disease than the literature tells us. And I think we will be able to treat everybody, for sure.
The hard part is going to be figuring out who to treat when. I put the newborn screen results into the abnormal newborn screen results into 3 categories. One of them is the classical, and we have a good idea what to do with that, and Dawn's talk was really good at how to manage that. For that group, it's a little bit more common than was historically thought, but not a lot more common. So we're still talking about a pretty rare disease. Then there's the non-classical, but clearly disease-causing, and that one is substantially more common, but still a rare disease. But the biggest number of abnormal newborn screens, the way that testing has been done so far, and where most of the cases where they found like the more common than 1 in 1,000, comes from is what I think of as the controversial changes in the gene, the controversial variants. A143T is one of those There are several others, and the question is, what do we do with those? Because in all of the controversial ones, the majority of the patients don't have evidence of storage, but a small number do, and there is some evidence that there is, in fact, disease. The A143T, clearly there are people who have storage and need treatment, but the majority, even if you do biopsies on their kidneys and hearts, don't have storage. And so what do we do with this? We're still working on that. There's also a group that don't have storage, but where the enzyme that is made is toxic to the cells, and it needs different treatment. That's a very small subset at this point, but it gets confusing.
Thank you so much, Dr. Staci. Dr. Rob?
My question would be regarding the vitamin D that the doctor just mentioned about being related with the kidney. Is this a typical Fabry thing that you see on patients? Because myself and both my kids have very low levels of vitamin D, and I wonder if it's or not related.
So vitamin D is low overall in the population. What we used to call as normal levels of vitamin D were completely wrong. So about 10, maybe 15 years back, we have changed what is normal level for vitamin D. So the level itself is low in many, many, many people that feel normal. So if you check your level, you will see that. So that's one thing. Low vitamin D has nothing to do with Fabry. When you take vitamin D or when you get vitamin D from sun, normally, your kidneys activate it. So when you're checking vitamin D levels in the blood, you're not checking the activated form, you're just checking the normal vitamin D level in the blood. So the low vitamin D is not something that's a Fabry thing, it's just a general population that we're not in the sun as much as we used to be or should be.
Okay, and then I have a question, if it's possible, for Dr. Hopkins, and is that earlier there was a lady that mentioned about if there is a correlation within Fabry disease and autism or ADHD. I know that her question was regarding whether or not they can express it in different ways, but have you seen, if any, relation between autism, ADHD, and Fabry disease?
So we know that ADHD and impulse control issues are increased in Fabry disease. There is some animal model data that gives us hints about why that is. The nerve cells in the brain and the spinal cord are triggered more easily and overreact to stimulation. So we think that that is a driver of that, although the studies that have been done have been looking at motor neurons, not the ones that would be involved in cognitive process. And there are several studies looking at that. As far as autism, nobody has done a good study to overlap that, but we know that people with Fabry disease have abnormal sensory processing, and you can tell that by the way they don't like to go barefoot and don't like certain kinds of touch and are sensitive to cold and hot. And then you have the overreaction emotionally that is fairly common in people with Fabry disease to both positive and negative stimuli. And some of the Fabry fog things are also going to contribute to that. So those things would all cause behaviors that overlap with autism. So I would not be surprised if it weren't increased to some extent, but there hasn't been a formal evaluation of that, as far as I know.
Thank you.
Okay, so my question is regarding the last talk. I saw that you recommended abstaining from any NSAIDs, and I wanted to know, I know that I've heard a lot of recommendations for people to take baby aspirin as a preventative for cardiovascular disease, or if they have a risk of cardiovascular disease. Also, NSAIDs seem to be one of the only ways to help cope with certain types of pain that might be coming together, coming with the Fabry disease and how it presents. Is there a limit?
So that's a good question. Let me back up and first say, if somebody I know has stage 4 chronic kidney disease or stage 3 chronic kidney disease, where eGFR is 50, for example, I would really, really not want to take NSAIDs on a daily basis at all. Once a month, when you're well hydrated, you can get away with it, but once or twice a month is what I would say. And the other end of the spectrum, what if your kidney function is completely normal? In a normal kidney function, again, I would really not want somebody to take NSAIDs on a daily basis anyway, but you might be able to get away with a higher dose more frequently, so once a week maybe. What I really know for sure is daily NSAID, especially when there are other risk factors for kidney disease like dehydration or diarrhea going on, would cause kidney problems.
So that's including low-dose aspirin.
I would exclude. Low-dose aspirin is not part of this discussion. I agree. Low-dose aspirin would be safe from cardiac or stroke prophylaxis, heart disease and stroke prophylaxis, and some of my patients actually are on a full-dose aspirin from the heart standpoint as well. That would be okay as well. The problem with aspirin is the high-dose aspirin, BC powder. BC powder is basically much higher dose aspirin. It's 4 times the dose that's in a regular aspirin. Those kind of levels gets us in trouble.
So another thing to think about is there are options besides, so the aspirin is used for stroke prevention because it's cheap and readily available. There are other options for that. So if somebody has significant kidney disease and we're worried about really optimizing the protection of their kidneys, we will change them to another platelet inhibitor, which is what aspirin does for stroke prevention. That is not processed through the kidneys, so it's not contraindicated. That is more expensive, and so there is controversy about when to do that. Usually for my patients, I tell them no regular use of NSAIDs other than the aspirin for stroke prevention, and we'll use it very rarely for crisis management with very severe pain, including sometimes migraines, things like that, but not as a regular medicine or a go-to medicine. We look for other options.
I have 2 quick questions. What's the best way to what do you recommend getting more vitamin D for Fabry patients? What's the best way to get it?
Over-the-counter cholecalciferol or natural vitamin D. It comes in all kinds of strengths, starts from 400 units all the way to 5,000 units. And I would take a small dose every day, maybe around 1,000 units, 500 to 1,000 units. But there is a downside to taking too much vitamin D as well, right? Like there is nothing that's risk-free. If you have too much vitamin D, calcium goes up and then you get kidney stones. So I've seen patients like that as well who come to me with kidney stones. They're taking over-the-counter vitamin D, they're taking their multivitamin with vitamin D, then they're eating their Tums, which has vitamin D. So they're getting a lot of vitamin D, and then they get kidney stones. So there's a balance. I would check the level and treat if it is significantly low.
And also, I've read somewhere that the sun absorption is better on your torso than your arms and legs. Is that true?
No, the sun absorption is everywhere. The challenge is the risk of melanoma and skin cancer is directly correlated with the amount of sun exposure. So instead of saying just go out in the sun 20 minutes, I give them a pill. Because I am not sure at what level the melanoma risk, because it's very different depending on your skin type. Depending on your skin
And
type,
on your
risk
family
changes.
history.
And family history. So yeah, but that would be the natural way to get vitamin D, is to be in the sun.
Okay. And we monitor vitamin D levels in my clinic. In Cincinnati, it's cloudy all winter, so nearly 100% of the population has vitamin D levels that are lower than we want. But, you know, there's a little bit low and there's very low, and so the degree of supplementation that we give varies depending on what the measured levels are and how the patient's doing. Teens or single digits?
Yeah, less than 10 would be very, normal's 30 to 60. 25 hydroxy vitamin D level, normal is 30 to 60.
I might be confused, but is it Charisse or Tracy?
Me?
Neither? Yes.
Yeah, sorry.
Tell me again.
Charisse.
Yes, okay, good, I got it.
Yeah,
I
you
try to remember everyone's names, but sometimes I'm unsure.
She's my mom, so it's confusing sometimes. You mentioned about the GLP-1 for helping possibly curb some of the side effects of the kidney disease. Have you seen any studies on tirzepatide to see if that would also help? And also, have you noticed or seen any studies that have shown Fabry can cause issues with the weight at all?
So let me answer the first part.
Yeah, sorry.
Weight, there is a clinical trial, randomized clinical trial with tirzepatide and with Ozempic. I'm blacking on the generic name. But anyway, Ozempic and Mounjaro both have randomized controlled trial in chronic kidney disease that lowers the risk of kidney disease progression and lowers the possibility of having a heart attack in chronic kidney disease.
Wow.
So the problem is this data is only about 6 months old. Yeah. So when I try prescribing, I get denied constantly. So insurance is not paying for it, and the price is significant for
Yeah, it's
both.
like $800.
Yeah. Well, now you can get it through their direct pharmacy, and that's $400.
Yeah.
Yeah, so different insurance plans have different coverages, and so it's really hard to know if they'll be covered or not. For chronic kidney disease, right now, nobody is covering it because the data is just so new. For diabetes and heart disease, it's much easier to get covered. So if I have somebody who has diabetes and chronic kidney disease, that is great. I know it'll get paid for.
Wanted to mention that for heart, though, if anybody has heart issues or has had a heart attack, look at Wegovy in your state.
The cardiology, the cardiology group where I work uses those routinely in broad spectrum of cardiomyopathies. So it hasn't been studied in Fabry disease, but it does have significant cardiac protective effects. And they said that they can usually get it, or they can often, I don't know if it's usually, they can often get it covered if you have evidence of heart disease. In the case of Fabry disease, ideally we would like to do things to prevent the heart disease because we know it's such a major risk factor. Getting it for that, that hasn't been studied, at least that I have seen. The other part of the question, is there a predisposition to obesity In males, the answer is no. Males with Fabry disease tend to be a little underweight. There are some males who have weight problems, but that's probably not due to the Fabry disease. Females, on the other hand, there's at least one study that did find some increased risk for obesity. The thought at that time, at least, was that that was due to the discomfort in the low energy levels interfering with exercise. But there is not a contraindication for these drugs as far as having Fabry disease doesn't make you less of a candidate. And because of the risk for kidney disease and heart disease, it may have some actual benefits. At least the nephrologists and cardiologists that I work with think that it will, and I trust them. The patients that I have had that have been on those drugs have tolerated them well and responded in the way that was expected for the reason they were being treated, which most of the time has been weight loss.
I have a comment, just adding up to what she said. On the last conference, I was on Jardiance for the lymphedema, and it was working fine. But then the insurance started not approving it because I didn't have diabetes. And I don't know, that's why it's so important to have all your doctors talking to each other. So my PCP, my neurologist, and my cardiologist, and my geneticist, they talked, and I don't know what they did, but I'm on Monjaro, and they proved to insurance that it's helping me with the inflammation from Fabry disease, that I'm not swollen as much, and I don't pay anything. Insurance is covering for everything for the Monjaro.
So for the record, we are not recommending any of these drugs, and we're not allowed to because they're not approved. But the things that have been said apply, and they are worth thinking about. So discuss them with your physicians to see if you are individually a candidate.
Let's go to Tommy, and then we'll go back
Perfect
to the follow-up
segue.
question.
Given that a patient, and this question is for either doctor or both doctors, but given that a patient may be working with multiple doctors, in your experience, can you suggest best practices that would facilitate or streamline those communications between doctors in your experience?
I would say ideally they would be in the same healthcare system so they can see each other's notes easily. That would be the biggest challenge, right? Because if I am in the community and I cannot see Dr. Hopkins' note or the geneticist or whoever the patient is saying, I have to call and request them to fax the note. That right there is a big barrier to good care. So I should be able to see all your other physician records seamlessly, the testing results seamlessly. So ideally, if they are in the same healthcare system, that would happen. And then I also think it's important to see people who know Fabry disease. So find a Fabry nephrologist, find a Fabry cardiologist. Geneticists already know Fabry, so you don't need a specific geneticist.
You have to find a geneticist who's willing to see adults and willing to do longitudinal management,
Yeah.
which can be a challenge. A couple of other suggestions for that. One is have my chart, because it is now a federal law that you have right to whatever's in your chart. And if you can pull it out and your doctor says, well, I haven't seen that, or I don't know what Dr. So-and-so thinks, and you can pull it out and give it to them, then they have no excuse not to know what the other doctors are thinking. And you can do that. The other thing that is helpful a lot of times is to find the doctor who's most interested in your problems. And that can be a nephrologist, a geneticist, a cardiologist, a neurologist, a primary care physician. the one who seems most interested in helping you and will listen to you, have them be the central
The quarterback.
person, and that's who you go to first, and then they can help you figure out what questions specifically to take to the other people.
And I have to say, come to the conferences because you learn. Knowledge is power. So my nephrologist, he had no idea what Fabry disease was, and he gave me some wrong information, even after my kidney biopsy. And I came here, I learned, and I went back and I told him he was wrong. And I gave him all the information from the conference that I had taken pictures of. And he totally went to inform himself, and now he's taking care of me the right way. So knowledge is power, and you have to advocate for yourself.
Thank you, Nara. We have is it from the?
Yeah, question from the
webinar?
chat.
Okay.
When severe activity and exercise intolerance is at play, what steps should be taken to understand and support what's going on?
So, there's a lot to potentially talk about there. One of the things is if you want to get into better health, which has been mentioned, just generally better health, has been mentioned several times today, getting more exercise is going to be essential to do that. When you start getting exercise and you have increased activity, that is, especially when you're getting started, going to irritate your Fabry disease. So you'll have some pain related to that. If you continue to exercise, not push it until the point that you're having crisis and are curled up in bed for days, but exercise as much as you can and build up slowly. As you get into better shape, most people will experience less pain and they'll be able to tolerate it better. But that's a long-term process. It takes months to get to the point that you're starting to see a benefit with that. As far as other things that we could talk about on that level, on that topic, there is a lot of other things going on. Some people will have more severe, just at baseline, more severe pain or more severe fatigue, and what can you do about that? Those are important questions we have limited data on. If you have specific questions about that, probably best to stop some of the people who are going to be at either here or at the camp and ask them individual questions.
When you're at the point of transplant for ERT, do you have to stop it beforehand, after?
No, you continue ERT through transplant. Before, after, you continue on ERT.
Thanks.
I have many kidney transplant patients who are on ERT ongoing, and they do better with ERT than without.
Yeah, the new kidney that you get presumably doesn't have Fabry disease, but the rest of your body still does, and it still needs to be treated.
Especially the heart.
Yeah.
Tracy, can you, the mic is right behind you.
I heard, so what she's asking is, can the new kidney get affected by Fabry? Yes,
Right.
but it'll probably take 20, 30 years. And so most of the times kidney transplants last on an average 20 years. So I wouldn't worry about starting treatment because you want to prevent new kidney from getting Fabry disease, but it's more about the heart disease. If you're not on ERT, the heart disease will progress significantly.
Yeah, that was the case in my case. I was diagnosed when I was 54. So and the only reason I was diagnosed was because I had a cardiologist and we monitored my heart because I have a heart murmur. So he noticed that the meds that he was giving me, I have that thickening around the walls of my heart. And he was giving me meds to try to thin them out. And I was on it for a while, and he noticed, we did an echo, and he noticed that it wasn't working, so he recommended me to Mayo Clinic. And that's when, they performed that test, and I found out.
Any more questions? And as Dr. Rob said, Dr. Rob and Dr. Staci will be at camp for those of you going to camp. So if we have no more questions for now, I'd like to zip right into an 8-minute video. Thank you so much
Thank you.
answering questions.